Susan asked me to come and talk a little bit about the work that I did at the U.S. Department of Health and Human Services in the Administration on Children, Youth, and Families. But she said, don't so much just tell me like the typical conversation that you've been having with people about making the case about why this is important. Tell us how you used the new science to change the direction of policy and practice at the federal level. So I'm going to try and do that today with you all. So this is a little bit of a different kind of conversation for me. Typically, I do the making the case presentation, and I have a beautiful slide deck that Brian Samuels and I created over the last 3 years. But that's not what I've been asked to do today. I've been asked to tell you the how we did what we did. And so I'm going to try and toggle between a making the case conversation and telling you how we did what we did. And it'll be a little clunky because this is the first time I've done it. It's 3 o'clock in the afternoon and I have just developed a killer sinus infection. But I have a whole room of protective factors here that's going to be with me. And so if at any point my toggling between these two layers in my presentation don't make sense, like I lose you, just throw a flag, okay? And I'll come back and I'll try and be more explicit about whether I'm making the case to you about why you should do this, or I'm giving you some sense about how we did what we did, because the most important layer of this conversation, I think, is neither the making of the case or the how we did what we did, but rather what you do in your head while I'm talking, about how you can use the what we did in your own organizations and in your own communities. So a little multi-layered here. We'll see how this goes. You're going to have to participate really strongly with me to make this work, because I'm going to show you mostly a lot of words and not a lot of pictures here, because at the federal level we deal in a lot of words that that end up being policy. All right. So you guys with me so far about sort of this multi-layered? Okay, terrific. Good job. Okay. Before I get started, an aside. And I've heard a lot of people say this today, but it's worth saying it here. I didn't know that I was going to say I've heard this several times today, but I use words really interchangeably in this discussion, because I think that it is this one science that tells us it's not just the adverse childhood experiences, it's not just trauma or toxic stress, there's the brain science, there's child development, whether you're on target or off target, whether you've been derailed as part of your experiences. The domains of well-being, social and emotional well-being, trauma screening, functional assessment, evidence-based interventions, and progress monitoring. So if you don't get lost in the 3 layers, you'll probably get lost in me using these words sort of interchangeably, because I think they do roll up to a larger whole that helps us understand not only that there's new science, but that you can make it incredibly actionable and transform your work and how we live together. So before I give you a little bit of an overview of the steps along the way, it's probably worth me just being explicit about the what we did, or at least what I think we did at the federal level over the last 3 years. We started by spending weekends and afternoons reading a lot of research. And if we went through one box of highlighters, we went through a dozen, just really combing through the research to say, is there something here that tells us a different direction that we can go? Is there a way to make actionable this burgeoning amount of research that is occurring? Is there a way to think through the adverse childhood experiences study and the brain science and the small studies about using trauma-focused CBT and helping us to really shift the course of federal policy? So over the last 3 years, we've begun to really talk about integrating safety, permanency, and well-being, rather than focusing on safety and permanency, which child welfare does very well, and we'll get to well-being, or we're already doing well-being, or well-being is really the domain of the education system and the mental health system, and we'll outsource that work. But really, how do we think through what well-being is in the context of child welfare and in the context, more importantly, of child development? So we really tried to start with the data and with the research. We developed a clear message. We rinsed and repeated multiple times. We tried to make it really actionable and measurable. We defined well-being, and we said, not only is well-being understandable in the context of child development, but you can measure really granularly the various components of well-being, not just whether a child is on target, is a child at the 95th percentile of weight and height, but we can know whether or not a child is on target socially and emotionally now, and I don't think we could maybe even 5 or 7 years ago. We tried to identify the army of the willing, and we found champions along the way who made an immeasurable difference in what we could do at the federal policy level. We used every lever that we could to focus on well-being and promoting social and emotional well-being and integrating the science. We used fiscal levers, and we tried to embed this work over the long haul. So the way that I'm going to sort of walk through this is I'll have several slides that key back to this slide, right? So start with the data. So you see I'm going to start with the data. Okay. So this is where I'm getting into the toggling back and forth, and now I'm going to use a slide about making the case. So this is a slide that we used often to help people understand that as children enter child welfare, that they come to us already with a host of trauma symptoms and mental health symptoms that need attention. That it's not just once kids get into child welfare that we don't do a good job of supporting them and then they look pretty rotten, but they come to us with a host of issues that are related to maltreatment and to neglect and to violent communities and to lack of access to resources. And what we really came to understand is that this is a pretty complex clinical picture. Often we think a bit solely in the realm of mental health, and we've got to get the mental health problems fixed, and so we'll send them to generic counseling. But if you really begin to think about how trauma overlays with mental health, different kinds of interventions and different kinds of approaches seem to be more appropriate than what we have typically used as our generic therapy services for kids and families. We wanted to know what the adverse childhood experience score looked like for kids in child welfare. And while you can't do that for every kid in child welfare, the National Survey of Child and Adolescent Wellbeing provides a tremendous resource to help us understand what kids and families look like when they come to the attention of child welfare. Are folks familiar with NSCA at all? Just a few, okay. It's an incredibly important study for you to know about. There's a wealth of information about what kids look like and what resources and supports are given to them, and then how they look afterwards. It's a longitudinal study of about 5,000 kids who become known to child welfare. So these are not kids in foster care specifically, but rather a representative sample of kids who come to the attention of child welfare and looked at longitudinally. And so the blue bars here is the original ACEs study. Looking by ACE, what percentage you find. And so 36% of people in the original ACE study had 0 adverse childhood experiences compared to 1% of kids in child welfare. When you look at the other end of the continuum, and we heard earlier that 4 seems to be an interesting cutoff about what happens with kids. But 4 or more ACEs for kids known to child welfare, 51%, compared to 13% in the original ACE study. And when you think about the body of research related to the ACE study and what it says about just that 13% and what they look like, imagine you've got this really indicated population of kids. We know this because of how kids come to us, but I will tell you, after we asked that these data be crunched, we were incredibly blown away by the magnitude of ACE exposure for kids in child welfare. And all of my citations where you can get these data are on the bottom of the slides, and we'll make sure we get them to you. But it's not just kids, of course, who become known to child welfare, and I think it's worth saying this about kids who are impoverished, because they are a very at-risk population for coming to the attention of child welfare. So this is the National Survey of Children's Health, which has looked at not the exact 10 overlay of ACEs. There's not an exact comparison, but they have 9 adverse childhood experiences that are listed down at the bottom. And so again, it's not an exact one-to-one correlation, but it gives you an idea of adversity in early childhood. So kids less than 2, kids 2 to 3, and kids 4 to 5. This is the general population on the left side of the slide. And on the right side of the slide are kids up to 100% of the federal poverty level. And you'll see that kids age 4 to 5, 60% of kids age 4 to 5 have already begun to accumulate adverse childhood experiences. So the magnitude of the problem that we have at hand is pretty significant, and it will take a transformational action for us to mitigate their needs. We also used a good deal of data related to the use of psychotropic medication for kids in foster care, because we understood this to be part of the same constellation of issues, right? So if a child is showing up with trauma and mental health symptoms when they walk in the door, and then they begin to look worse because they've been removed and they're bouncing from home to home, a not out of the ordinary experience for them in child welfare is to receive a psychotropic medication. This is antipsychotic medication, so this is a slice of a pie. But we used these data to compel people to understand the ramifications of doing what we typically do and providing the most expedient fix. There are a multitude of health repercussions for the use of psychotropic medications, and almost all of them are being used off-label for kids. Right, we don't know what the long-term impact of using psychotropic medication is for kids. But it's not an uncommon way that we try and fix this problem that comes to us. Right? So again, we tried to use these data about the magnitude of the problem and the typical way that we go about solving the problem to help people understand that we needed to do something vastly different. So we tried to use research to help us point a different direction. We relied very heavily on the Adverse Childhood Experiences study and helping people begin to access that research. I'm guilty of having not known about the Adverse Childhood Experiences study before I came to work at the federal government, which was about 3.5 years ago. Recently moved to a different organization, but I've been doing child welfare work for 20 some odd years at this point, and I think I'm relatively reflective of the extent to which people understand that this study exists and what the implications of it are. So educating people about the research was a core component of what we tried to do. We also relied quite heavily, as we've talked all day, about the brain science and the import of it. Let's see, let me go back. I've got a little video in here. Let's see if I can access it. Yep, there we go. So I'm going to show you a cute little 3-minute video from the Center on the Developing Child. because I think it does a good job of helping folks to access the information in a way that activates a different part of the brain.
What if you could take action to reduce crime, improve health and education levels, increase family incomes and state revenues, and improve the quality of life in communities throughout your state? Where would you begin? Science tells us that we may find the solutions to these complex social problems in early childhood, when the architecture of the brain begins to form. Brain architecture is built over time and shaped by experiences, starting in the earliest years of life. The most important experiences come from the environment of relationships that interact with each child: parents, extended family, and caregivers of all kinds. But serious adversity early in life can disrupt healthy brain development. Both brain architecture and behavior are increasingly difficult to change as individuals get older. So what happens early matters for a lifetime. Now imagine you can take action to improve the lives of children and the quality of life in this community. Where and when would that action be most effective? The links between policy, parenting, and brain architecture become much more clear when we can see how formative events and family and community environments affect child development. For example, policymakers want to make their communities safer, or improve children's learning, or reduce the cost of chronic health problems. A child raised in this environment may experience lower levels of stress and more opportunities for learning. That leads to sturdy brain architecture and a healthy stress response system, which prepare the child to achieve higher levels of literacy and other skills early in life, and later leads to improved school achievement and decreased dropout levels. Positive early experiences can also reduce levels of obesity, diabetes, and heart disease. Increased health and education levels can have positive effects across society, like reduced crime and increased income and tax revenues. Policies affect both individuals and communities, so making wise choices that support early brain development can improve health, behavior, and learning throughout life.
I do want to have just a quick aside, though, about this video and something that Jane said earlier this morning. You know, much of what we've talked about today is focusing on those very early years and making sure that kids get a strong start from the very beginning. Jane talked about kids 12 and older who are on the verge of a psychotic break or at risk of that. And so what I have come to understand or to interpret out of the science is that, you know, intervention and plasticity is available at many points along the continuum, which I think has implications not just for the earliest years, but how we intervene for adolescents and how we intervene for parents, the two-generation approach that Susan has been talking about. But one thing that I've not heard us say a lot about today that I just want to bring to the fore is that I think it also has really huge implications for what we offer to our workforce, right? Because we can train our workforce around trauma-informed care and helping them to understand their triggers, but our workforce comes to us with ACEs, right? And so I've been sort of toying around with what are the implications of how we train and what we provide as supports to our workforce, because we can help kids and families be more regulated, but if our staff is dysregulated, we don't get very far. Right? The words self-regulation have made a tremendous difference in my marriage. right? So, helping people to access the right kinds of supports for them at the right time is also important if we are going to have the kind of transformative impact that we are looking for. All right, so back to my presentation. The next step, or one of the steps that we tried to take, was to really develop a clear message and repeat. The first thing that we did was to write it down. Is anyone here familiar with this information memorandum that we put out? Just a couple of people. Okay, so this is really the foundational document of what we did at the federal level to begin to shift policy. We wrote a 22-page tome that laid out the research and made a compelling argument about why we had to begin to focus on well-being. You all know that we've not defined well-being. There's not really been a focus on well-being and child welfare since ASFA was passed in 1997. And we undertook, we held our breath and we hoped and we put it out there. And we said, here's what it is, here's what it's based on, and here's what we think that you can do differently as a well-being champion in your work. And so I would encourage you to take a look at this information memorandum if you've not. Again, so I'm going to toggle back and forth. This was us making the case. You too can put out an information memorandum in your community or in your organization saying, here's the brain science, here's the ACEs study, here's the work that here are the policies that already exist that say that you have to do well-being that we're not really using. Here are the ways in which we can begin to implement screening, assessment, and evidence-based interventions. Here's a way that we can begin to shift and turn this ship into a different direction. So we wrote it down, and we used this document every single time we had a conversation with someone, which was often. If Brian Samuels, as commissioner, prior to his being executive director at Chapin Hall, did a speech about promoting social and emotional well-being or getting to well-being or research to practice well-being, if he did that once over the last 3.5 years, I bet he did it, 250 times. We had him on the road all the time. We took every single opportunity we could to repeat the message. And we repeated it. And that was really the only message that we had, right? We wanted people to hear it 7 times. We were just really clear that if we took up something else, if we tried to do something more or get really far down the road, that we would have left people behind and not been really clear with folks about what this meant and what the implications of it are. So I would encourage you, as you are doing this work and thinking about your own transformation in your own communities, about how you develop a set of presentations and metaphors that you can help people to gravitate to and understand more deeply than they would if they heard it once. And to that end, we wanted to say safety and permanency are vital but insufficient. That we had to begin to focus on child development. We serve kids, and kids develop. And what more important thing can we possibly do as a system that a $9 billion system? If we don't focus on kids developing well, what is there to do? We must, it is imperative that we begin to understand what a developmental trajectory is for kids, and how we intervene to get them back on track developmentally when they've been derailed from adverse childhood experiences and toxic stress and trauma. And so this is the appendix to the document that I just showed you here. So the last page of that document is this. And what we tried to help people understand is that it's really measurable. who in here remembers those growth charts when you had little kids, 95th percentile, the little, right? We can do that with this now, and we couldn't before. By developmental stage, infancy, early childhood, middle childhood, and adolescence, and across the domains of well-being. So we scoured the literature, and everywhere we looked, cognitive, physical, emotional, behavioral, and social domains of well-being kept popping up. And you're like, well, of course, those are the domains of well-being. But we in child welfare, we had never seen this written in this way, and we did not understand, at least Brian and I didn't, that in each stage of development, these are progressing. And if we measure them, we can understand whether or not a kid is on target or not, and whether or not the interventions that we are using are bringing them back on target or not. So it's measurable, and it's actionable. And so we tried to, in every opportunity that we could, say, use trauma screening to understand what the trauma experiences are of kids. That was really the first slide I showed you with the bars of kids entering foster care. Once you understand what the trauma experiences and symptoms are for kids, use a functional assessment tool that's validated and standardized and ideally normed to the general population so that you can tell where a kid is, to understand where they are, and marry that with a good clinical assessment as needed. Pick an evidence-based intervention that's aligned with those needs and implement it, and see if you're going to get to better outcomes by using that same tool again to see whether or not a kid moved, right? And we have lots of examples of that. I'm just going to show you one. This is a very small study, Sharanga. The citation is cut off at the bottom. These are kids aged 3 to 6 with PTSD. CBT, cognitive behavioral therapy intervention, was implemented, and a functional assessment tool was used prior to and after the intervention. And what you see is that for kids who were being treated for PTSD also showed improvements in other symptom areas: major depression, seasonal affective disorder, ADHD, and oppositional defiant disorder, which, by the way, are the things that most typically show up for kids in foster care. And so what you see is that it's not only measurable, but it's actionable, and you can tell whether or not kids are getting better. And that was an epiphany for me. Having been a clinician at a group home for kids, teenagers who were child welfare involved or juvenile justice involved back in the early 90s, where kids came into foster care when they were 4, and I was seeing them at 16, and I had no idea if they were getting better or not as a result of what I was doing with them, and my best guess is that they were not. And so the idea that we can use these data to refine how we intervene with kids and families was tremendous. It is tremendous. So using assessment and EBPs and progress monitoring was a core component of the how we did what we did at the federal level. It shows up in almost every document that we put forth over the last 3 years, and I think provides a roadmap for you to think through, how do I choose mindfully the functional assessment tools that I use in my organization or in my community? How do I choose mindfully the array of evidence-based practices that we as a community put into place, and who gets access to those and when? And then how do we monitor to see at the community level or at the organizational level whether or not kids are getting better and families are getting better? We tried to connect the dots for folks. Because we kept saying these things over and over again, but we were worried that, one, it's at the federal level and not everybody sees what we're doing, and two, it might have been easy for people to think that each of the things that we were doing was a standalone or a disparate thing. And so we put out a couple of documents that I want to tell you about that just reiterated what we were saying. But I can't tell you how many people came up to me after we did these and said, I can't believe you all put these documents out. I've never seen the government do that before. You're telling us what you're doing? And so we put a letter out in July of last year that said, we think that there's a child welfare reform process underway, and we want to build on it. And the core of the strategy that we're putting forth is about promoting social and emotional well-being using the new science that is available to us. And we've done that in several documents and in different ways. And we want you to understand, field, country, that while these things may seem like individual things, they're not. It's all part of a whole. So much like I talk about ACEs and toxic trauma and trauma and toxic stress and brain science is sort of part of a whole. These two were all part of one whole thing that we were doing. Not separate things, one whole thing. And again, it's finding a message and then helping people connect the dots among them. The second document that we put out was at the end of last year that articulated the approach again. Hello, we're doing this, and here's what it is, and we're reminding you that this is what we're doing. And more importantly, we want you to understand that we pulled every fiscal and policy lever that we could over the last year and a half in this direction. We want you to know that we put out $46 million on the street towards this end. And we pulled a policy lever, the Child Welfare Waiver Demonstration Projects. We want you, field, to understand this because we want you to come along with us. And at the beginning, we sort of, crossed our fingers and hoped that people would come because, well-being had been sort of this taboo thing that people didn't want to do. But people came along, and we were so delighted that, you'd get 80 or 90 applications for a funding announcement that in many ways articulated much of what we were hoping people would understand. We could not have done this without partnerships, and you all know this in your work, right? So I'm not telling you anything new or different here. But sometimes there are partners who you think, either at the federal level, Medicaid, how would child welfare ever partner with Medicaid? That's never happened before. Or how might we partner with the police department? Or how might we partner with the business community? We've never done that before. But going back and trying again, or trying for the first time, can yield tremendous results. When you have the right science behind you, and you have an approach that people can understand and gravitate around. We put out 2 letters with Medicaid, Centers for Medicare and Medicaid Services, and SAMHSA, Substance Abuse and Mental Health Services Administration. The first one was about the use of psychotropics. We wanted folks to understand that we were concerned about the potential overuse of psychotropics, and we wanted to make sure that the use of psychotropics was effective and was the right thing to do at the right time for that particular child, and that there were a number of first-line treatments available in the field that were not being used at the same level as the use of psychotropics. And we wanted people to understand that at the federal level, we were partnering to begin to shift away from a perhaps overuse of psychotropics and at least minimally scale up the use of first-line treatments. The second letter, addressing trauma with children known to child welfare, was really about okay, we've said all these things over the last couple of years, but how do we create financing structures that allow us to do this work? Because as Susan said, unless there's money there to do this work, it's very hard to scale up a set of evidence-based practices. And so this letter helps articulate the funding streams in child welfare, in Medicaid, and at SAMHSA that are available to states and communities to organize their service array differently. CMS also put out a number of guidance documents that I hope that you'll take an opportunity to read because they point the way towards managing a service array that really begins to meet the needs of individuals with mental illness or children with significant mental health concerns. So in toggling back and forth between making the case here and how we did what we did, having people, your partners, really own this work and then forcing you to own even more of it is a great strategy for pushing the work forward. Non-traditional partners, partners who you thought that would never come to the table, partners who are old partners but could do even more or do things differently. And then it never hurts to shoot for the moon. So if you don't ask people in power to support your cause or to put information out into the world related to what you're doing and what you're trying to do, they'll never help you. But every once in a while, someone really important will understand the import of the work that you're doing and will help. This in July, when we released that second Tri-Director letter, Secretary Sebelius wrote a blog entry articulating the need to attend to and mitigate the work, let me say that differently, to attend to adverse childhood experiences and mitigate their impact. She released the letter and said, this is important to me at the department level, at the cabinet level, and we're going to continue to focus on well-being in much of the work that we do. So ask your governors, ask your legislators, ask the folks who you think might never be able to or interested in putting forth a statement about your work, because every once in a while, shooting for the moon works. We used every policy lever that we could find. The child welfare waiver demonstration projects, folks familiar with those at all? Yeah, okay, more head nods, that's terrific. So the toggling here is that every time there was a policy opportunity that came in our direction, Congress reauthorized our ability at the federal level to allow states to have a waiver in using their Title IV funding. We'd stop and we'd look at it and we'd say, is there a way to integrate this focus on well-being into the work? Every single time. And it was often mushy and messy, and we had to organize champions around it. But when we announced to states that they could apply for waivers, we said we're going to have a priority. We're only going to be able to allot 10 waivers per year for the next 3 years, and those states that say they want to focus on well-being and promote social and emotional well-being will be prioritized at the top of the list. So we used every policy lever, and at this point, we've just approved the second round of waivers, and so there are now 17 states, and almost all of them said, yes, we want to do exactly this in the way that you've articulated it. It's a tremendous surprise and exceptional thing that happened. But again, as Susan talked this morning, there's big P and there's little p, and you're making policy decisions every single day as you sit in your office. And just taking the moment to say, how can this policy further this particular work can yield tremendous benefits. We also used funding levers, so we looked at every dime that was available to us, and we crafted funding announcements that put promoting social and emotional well-being, screening, assessment, and evidence-based interventions at the core of those funding announcements. And here are just 3 examples of funding announcements that we put on the street over the last several years. And the first 2 are sort of we sat down and we rethought how we might provide funding in a grant announcement. The last one is an example of one that has been in existence for quite some time, but we tried to rethink part of it. Traditionally, the regional partnership grants focused almost predominantly on providing substance abuse services to parents and did not focus as much on the well-being of the child. And so we tried to recraft that in a way that allowed for more emphasis on evidence-based interventions for kids as their parents were receiving substance abuse treatment. So again, looking at every dollar that comes across your desk and figuring out, is there a way to further the work? Embedding it for the long haul. Big P. At the federal level, as the Promoting Safe and Stable Families Act was being reauthorized, we worked with members on the Hill to integrate work around trauma into the legislation. And so you see the new language that was part of the Child and Family Services Innovation and Improvement Act of 2011. That Title IV-B agencies must include in their annual state plan to us how they'll monitor and treat emotional trauma associated with a child's maltreatment and removal, and protocols for using and monitoring psychotropic medications. So this was a small, large change in the legislation, but working with your legislative branch can and helping them to understand how even a small language change makes a big difference in the work that you're doing. States are doing this as well. Connecticut is got a lovely piece of legislation, comprehensive implementation for meeting the emotional and behavioral health needs of all children in the state. West Virginia provide children in crisis with early intervention, assistance with emotional needs, medical evaluations, etc. We also knew, and I said this a little bit last night, we also knew that asking people to focus on social emotional well-being could feel like something more added on instead of the transformative work that we hoped that it would be. And we used this slide to talk about a component of that, which is you can think about what you want to scale up, but you also have to think about what you want to descale. If coming out of this, you don't think about what to get to leave behind that is no longer aligned with this direction, and how to shift those funds into work that is aligned, then I think that you've missed the transformational nature of what is being contemplated here. I know that you all are doing that. That's why you're sitting in this room today. But I think our communities have to think strategically and together about this, because while it would be lovely to have a $700 million endowment to change early childhood education, I mean, that'd be terrific. But there's a lot of money that is already spent on services and supports in this country that could be redirected to focus on what is, in essence, the thing that derails development and that changes the life trajectory of so many kids and families. This is my final slide that really sort of talks about what we hoped people would leave with after we talked to them about focusing on social and emotional well-being, and that we asked folks to do this in everything that they did. Focus on child and family level outcomes. So not just those system level outcomes. Is there a case plan? How many times did the caseworker go out and see a child? How many times did the medical team see the child? So focusing less on process and more on, is the child getting better? Is the child back on track developmentally? Change your child welfare practice to address the impact of trauma and toxic stress. Monitor for progress in outcomes and see whether or not kids are improving or parents are improving. Take a developmentally specific approach. Achieve and actively promote healthy relationships and build capacity to deliver screening, assessment, and evidence-based interventions. So we're quite hopeful that over the next 5 years that we will see some shift in outcomes at the child and family level as a result of this new focus. We are looking forward tremendously to the evaluations of the discretionary grants and the child welfare waiver demonstrations to see whether or not this makes a difference. But if nothing else, I hope that we have changed the conversation in child welfare about what it means to focus on child development, what it means to understand whether or not a child is on target or off target developmentally, and what it means to put in place screening, assessment, and evidence-based interventions to make a difference. Thank you.